we will like to proceed with our next symposium, which is basically pre-paper presentation. So there will be a 10 paper presentation, each presentation consisting of 7 minutes with 3 minutes of question answer. So chair for this session with us are Dr. Yasir Waheed, who is working as Associate Professor at Foundation University, Islamabad. Dr. Shahid Rasool, who is working as Professor at Medina Teaching Hospital, Faisalabad. Dr. Lubna Kamani, who is working as Associate Professor at LNH, Karachi. And Dr. Muhammad Kamran, who is working as Consultant Gastroenterologist at Fezaiya Rutba Medical College, NPF Hospital, Karachi. So, as we are already short of time, so we will start to have video presentation of all this session. So starting with our first presentation, which will be done by Dr. Riaz.
So is Dr. Riaz is here? Good. So you have a mic with you. So meanwhile, so since they're uploading your presentation, so once you're finished, then you're here. Yes. Okay. So then you can answer the questions from the audience.
Can I ask आप लोग जो present कर रहे हैं, before you start, can you give us a 20-second thing about कि आपने research किसके कहने पर क्यों की? Just give us tell you what motivated you to do this work. I would love to hear that. I want to know why you wanted to do this. क्या कहेंगे? आप करें पहला present?
Yes sir. First. Yes sir. First is my presentation, the treatment outcome of Sofosbuvir and Velpatasvir in chronic kidney disease. So we assist. Actually, yes sir. So we are conduct this study in JPMC Hospital, Karachi. So most of the patients who came our department suffering from the hepatitis. So we diagnose them and proper treat them. Yes sir, just from our department and from our supervisors and just also me, we have decided to work on this research.
Bismillahirrahmanirrahim. My name is Dr. Riaz Channa, gastroenterology resident, Channa Postgraduate Medical Center, Karachi. Assalamu alaikum. Topic of our study: treatment outcomes of patients undergoing hemodialysis with chronic hepatitis C on Sofosbuvir in Velpatasvir regime. Introduction: Hepatitis C virus is highly prevalent in patients with chronic kidney disease. Direct-acting antiviral agents has revolutionized the therapy of HCV, including the patient with end-stage renal disease. However, the patient with HCV and CKD have the few treatment options. Limited data available regarding HCV treatment efficacy with the Sofosbuvir and Velpatasvir in end-stage renal disease and maintenance hemodialysis in South Asia. Objective: to determine the treatment outcomes of Sofosbuvir and Velpatasvir in chronic hepatitis C patients undergoing hemodialysis. Patients and methods. Place of study: Gastroenterology and Nephrology Department of Channa Postgraduate Medical Center, Karachi, Pakistan. Type of study: prospective observational study. Duration: January 2019 to October 2020. Laboratory work of initial screening for HCV was done via laboratory test for HCV antibodies. Only the patient has a positive result was further tested. Follow-up: all laboratory values were repeated at 12 and 24 weeks to assess the efficacy and side effect of the therapy. Dosage and duration: all patients were treated with a combination pills of Sofosbuvir 400 mg, Velpatasvir 100 mg once daily, taken per oral on empty stomach for 12 weeks. Inclusion criteria: chronic HCV active infection, patients who are undergoing maintenance hemodialysis due to end-stage renal disease, defined as a GFR of less than 30 ml per minute, which required weekly hemodialysis session to maintain the renal function. Exclusion criteria: decompensated chronic liver disease, malignancy, HIV co-infected patients, HPV co-infected patients, alcohol and other substance abuse. Total 120 patients screened for HCV infection before the hemodialysis. Lab results find ATR. Bilateral semester
Riaz, what were your the remaining findings and your results?
We have started the treatment Sofosbuvir and Velpatasvir for 12 weeks. So our primary outcome to see the outcome of the patient with ETR and treatment response. So the patients with end treatment response, mostly patient achieve the end treatment response, and about the SVR, 95% of the patients achieve the SVR in CKD patients. They are already in the hemodialysis patient and nephrology ward. 5 patients, they was relapse and they were further, but mostly the 95% patient have achieved the SVR, and then during the treatment there is no any side effect or occur, and just no hepatological any deterioration occur during the treatment. Then after that, the achieving the SVR, they remain on the dialysis after treatment.
Okay. So
The side effects, mostly patients have the complaining of the nausea and just like epigastric pain, and a few patients have developed the anemia. So
Okay.
mostly.
So what are your conclusions?
Conclusion is that, ma'am, during treatment, most patients have achieved the SVR, and they remain after achieving SVR. There was when dialysis, no hepatological deterioration occurring during the treatment.
Great. So the question time.
Any questions? Yes, mostly patient was with the chronic hepatitis C. Just 5% patient with the compensated cirrhosis, but other patient was in exclusion criteria. Decompensated cirrhosis was in the exclusion criteria. Just 5 patients was belong to the compensated cirrhosis, but other all are patient from the chronic hepatitis C.
Did you do any studies for fibrosis assessment or
No, sir, no fibrosis assessment. Just on the ultrasound basis we can.
APRI वाला scores नहीं थे? You don't know उनके क्या
Yes.
underlying diabetes. Okay, but the response rate was 95% SVR.
Yes.
That's very good.
I would like to take if there is any question from chair.
Okay, so Riaz, good study. I think we need more data from this part of the world regarding
Yes,
this. So you said that 5% were compensated cirrhosis and the rest were non-cirrhotic.
Chronic hepatitis C.
Okay, they were non-cirrhotic.
Yes.
No patient with decompensated.
Yes, sir.
Because many times we see patients who are dialysis dependent, and patients come with ascites and end-stage renal
Yes.
failure, and they are Hep C positive. So even the guidelines also are still, they are not very clear on the treatment with Sofosbuvir patients who have end-stage renal disease.
Point, अगर आपने कोई assessment नहीं की, how do you know they were compensated cirrhotic and not just chronic HCV?
Yes, sir. On ultrasound, we can just see the liver parenchyma and
So I
splenomegaly.
think there's a learning point here कि ultrasound पे reliance is day and age में for determining the degree of fibrosis or liver disease. I don't know. क्यों जी आपका ख्याल है? मेरा ख्याल है कि थोड़ा इसको हमें ये emphasize करना पड़ेगा कि यार research में खास तौर पे when you're doing it you have to, because इन सब की long term prognosis different है.
Yes, sir.
So ultimately जो आपने चीज शो करनी है स्टडी में वो outcomes हैं इनकी. Did your treatment improve the outcome or not? So it will be important to assess, but it should be more than ultrasound. That's my personal opinion.
Yes, I think I agree with Dr. Arif. There should be more parameters to.
Yes, sir.
Dr. Kaman,
Basically.
can I add?
Yeah, sure.
Basically, I work in SIUT and we have the largest transplant center dialysis center in Karachi. I have 2 papers on, one paper on dialysis and 2 papers on renal transplant with treatment of Hep C. You rightly said only the liver ultrasound will not show that they are compensated or decompensated. The parameter we use were the ascites, the SAG ratio and platelet, because the difference in the SAG. Plus, if there was any discrepancy, we went for the esophageal varices for the endoscopy. So, although the Sofosbuvir didn't have any, I have the paper on Sofosbuvir, Decla and ribavirin, and even with the ribavirin, the anemia was not that common in these population which we suspected. So as you said that the Sofosbuvir has some problem and you don't have data, that's the issue, that the Sofosbuvir didn't show any further decompensation, although their albumin pattern increased in our population, which showed that maybe the liver function was getting better, the synthetic function was getting better.
By the way, just a qualifier, okay, the questions from us are not meant to be a viva or to torture you, it's to give you some ideas from our experience कि आप इस स्टडी को और इम्प्रूव कैसे कर सकते हैं. You guys will all have done a great job. It's a big initiative when they set up to do all this research. So I commend you for that, but please don't take this criticism as a harsh criticism or something. This is to help you improve. और मैं आपको बताऊं इसमें बहुत सारी टीचिंग आपके सुपरवाइजर्स की भी है. Because हम जब आप गाइड नहीं करेंगे and we don't give you the right parameters for the study, you can't do it. So I think it's a learning experience for all of us. So please take it in that respect. But well done. I mean, these are great.
There is a very easy way that how do you label someone having advanced fibrosis or not. So there is a simple scoring system which may not be holding very good in patients who are on hemodialysis, but you can get some idea on FIB4 and EPRI. So there are cutoffs, and you may define cutoffs for your hemodialysis or endothelial patients also. So all over the world, advanced fibrosis in hepatitis C is being treated in a different way as compared to the patients who do not have advanced fibrosis. So this is important.
Is there any comment or question from Chair Dr. Lubna Kamani or Dr. Shahid Rasool?
I think so. It was a good attempt, and we should not discourage this young gentleman. But definitely, there's always room for improvement, and we are all in a learning phase. So we have, as Dr. Zainam said, that we have FIB4 and APRI. I know that in a government setup, a fibroscan facility is sometimes not available, but in Channa, I guess fibroscan is available. So you can do fibroscan, which will give you a fair idea regarding fibrosis and the extent of fibrosis, because ultrasound is operator dependent. So even if you're relying on ultrasound, then you have to have one operator, usually in research, or one doctor does all the ultrasound of that research participant in order to, decrease the confounding factor. So if the different doctors are doing every time ultrasound in this study population, then they will have different results. So I guess we are already lagging behind, so we should move on to the next presentation, because we have a double presentation in this session.
Yes, sir. Thank you, ma'am. Thank you. So we will proceed with our next presentation. I would like to call Dr. Abeer Altaf.
Assalamu alaikum. My name is Dr. Abeer Altaf, and I'm going to be presenting upon the topic of severity of COVID-19 and its association with liver injury in patients without pre-existing liver disease. So COVID-19 requires no introduction. Since a year, it has affected more than 65 million people worldwide and has claimed lives of 1.5 million individuals. Pakistan alone is experiencing its second wave with confirmed case tally exceeding 4 lakhs and death toll surpassing 8,000. And the number is increasing day by day. The most common symptoms of COVID-19 are fever, cough, and tiredness, followed by shortness of breath and chest pain in more severely infected population. COVID-19 doesn't just involve the lungs, but also other organs like the skin, kidney, brain, gut, as well as our topic of interest, the liver, as shown in this pictorial representation. So how does the COVID-19 affect the liver? The 4 main theories are: 1. We are localized in systemic inflammatory response due to the cytokines. 2. The muscle injury, ischemia, and cardiomyopathy. 3. Direct viral effect due to ACE receptors present on the hepatocytes and the cholangiocytes. And 4. Because of the drug injury. So the aim of our study is to evaluate the effect of COVID-19 in patients with no history of liver disease and see its association with its severity. This study was conducted at Ziauddin Hospital, Clifton Campus, Karachi. This was a single-center retrospective observational study. Patients admitted from 15th April to 31st July with a positive nasopharyngeal PCR, COVID-19 PCR were enrolled. Initially, the total number of patients was 142, out of which 7 were excluded due to history of pre-existing liver disease, leaving the final count to 135. COVID-19 was categorized as mild, moderate, and severe according to the international guidelines as shown in the table. Results. Our demographic data revealed that the majority of the affected population were males and 78% of them were discharged. 52 of them were suffering from mild disease, 34 had moderate illness, and 48 of them suffered from severe disease. Hypertension, diabetes, and cardiovascular disease were the most common comorbid conditions with COVID-19, with CKD, smoking, COPD, obesity, neurological manifestation, and alcohol intake rounding out the rest of the comorbidities. Chief complaints were fever, followed by shortness of breath and cough. Individuals also complained of muscle pain, nausea, vomiting, diarrhea as well, and a small minority also experienced hematemesis and jaundice. We took a percentage of patients with severe COVID-19 and patients with derangement and liver function test, and we found out that 4% of them had abnormal total bilis, 18% had deranged ALT, 26% had raised AST, 32% had deranged gamma GT, and 20% had low albumin levels. AST was doubled to check its association with severe COVID-19 variables, and its association was present as evidenced by a higher SIR score, raised procalcitonin, raised ferritin, lower PaO2 on admission, a higher SOFA score, and a high chances of multiple organ failure, all with significant p-values. COVID-19 itself, severity was assessed individually, and it showed that patients suffering from severe disease had raised WBC count, neutrophilia, lymphopenia, raised creatinine, higher AST, a higher GGT, low albumin, and a raised INR. Inflammatory markers like ferritin and D-dimer derangements were also present in severe COVID-19, and these individuals had higher Apache 2 and SOFA scores. So in conclusion, large number of patients suffering from COVID-19 have evidence of liver injury, which appears to be secondary to an inflammatory response as evidenced by higher levels of PCT, ferritin, and D-dimers. The degree of liver damage correlates with severity of COVID-19, hence close monitoring of these variables is important as a part of the assessment of the vulnerable population. In the end, I would like to give homage to all the frontline doctors who sacrificed themselves while fighting an ongoing battle with COVID-19. Thank you.
Thank you, Dr. Abeer. We will take a question or two if is there any comment from chairs.
The question is the liver inflammation or the activity that you saw, did that have any implication on the clinical outcome of the patients or the clinical course of the patients? I don't think you have the data, but can you just tell us subjectively if there was any difference?
Yes, Assalamu alaikum. Subjectively, what we saw in our study was as patients who were suffering from more severity of COVID-19, they had higher levels of liver injury as seen by their derangement of liver function test. And these individuals ended up suffering from more severe disease. They ended up having a higher hospital stay. They ended up getting intubating. They ended up having ventilated and eventually even die. So the severity of COVID-19 was was then associated with derangement of LFTs, and once patients' LFTs were improving, we also saw that their overall comorbid status and the overall clinical status was also improving as well.
And you don't think this was part of like a this is direct liver?
This is an entire multi-organ failure, because it's not just the liver that was being involved, but patients also had AKI, they also had acute lung injury as seen by their SOFA and CLIF SOFA scores as well. So, and they also were on vasopressors as well, they were given multiple medications. So it was not just a single liver injury, but per se as many different organs were involved as well.
And if there was more liver injury, was the recovery more prolonged? I mean, just trying to look at parameters to predict the course of COVID. Does that help in any way?
What we saw was that when we see patients, we see usually their ferritin and their D-dimers and their LDH and their CRPs, and we basically say that these are the inflammatory markers that are associated with more mortality of COVID-19. What we saw in our study was that patients with AST was also associated with COVID-19 as well, severity. So AST, gamma GT, low albumin, hypoalbuminemia, all of these markers were also, and they also should be checked in patients with COVID-19. And to remove any confounding factors, in our study we removed any patients with pre-existing history of chronic liver disease. So only those with no history of chronic liver disease and they eventually developing liver injury, they were included in our study.
This is very clear thinking.
Dr. Abeer,
Yes.
couple of questions from my side. Did you find any gender difference between male and female, the severity of the liver disease during COVID? Number one question.
Yes.
Number two, did you follow these patients once they are out of the hospital? How much time it took LFTs to become normalized in these patients? And what about excluding other causes of liver derangement like drug induced? Because before coming to the hospital, patient might have taken multiple doses of paracetamol because of the fever, antibiotic, over-the-counter drugs, NSAIDs, because these are all could be the confounding factor and can affect liver. So how did you control that?
Okay, so regarding the first question that you've asked, as we have all seen, the patients initially who were admitted with COVID-19, most of them were males, and the more severe population also had a male predominance as well. So that was your first question. The second question that you asked was, can you repeat it? Yeah, so it was
second was after these patients got discharged, did you follow these patients? How many days did it take the LFTs to get normalized?
Okay, so for the patients who were discharged, they usually were following with the respiratory clinicians. So they didn't really come up to a gastroenterological follow-up, so it was difficult to see. However, the ones with CLD who had COVID-19, they obviously came to our follow-up, so we saw them. We didn't include them in our study, but we saw them when we found out that once they were becoming better, their COVID-19 liver injury was also getting better. Another few patients who came to our follow-up were the ones who had liver injury with COVID-19. And then after about a month or so, when they came back to our clinic, their SGPTs and their SGOTs were getting better.
So can you extrapolate and say that CLD has some impact on the prognosis of COVID?
Obviously, because CLD patients, they already are immunocompromised, and on top of which they ended up having COVID-19, and then they develop, like say for instance, cytokine storm, then obviously they're going to have even more worse
No, but is this your data, or you think this is the case?
No, we didn't include CLD in our study.
So I don't think we can comment on this, but it would be a good area to look into.
Yeah, exactly.
Right.
CLD per se was completely separate. We excluded it from our study.
I think between Lubna and myself, हमने आपको बहुत ज़्यादा question मुश्किल पूछनी है, but अभी last question का जवाब नहीं दिया आपने डॉक्टर लुबना के last सवाल का.
जी, ma'am, can you repeat your last question?
Third question, Lubna, आपका क्या था?
The confounding factors, which was very important in this case, because before coming to the hospital, these patients have high-grade fever and they've taken multiple doses of NSAIDs, antibiotics, and the main drug, which is paracetamol. How can you say that this derangement of LFTs is because you have not given any history of medications in your presentation? So did you exclude how many doses of paracetamol and everything? And what about other causes of acute hepatitis? That was excluded or not?
No, that was not excluded.
I have an observation that I want to tell. I'm Dr. Yasser. First of all, Dr. Abeer, it was an excellent observational paper that you have presented.
Thank you.
I just wanted to add upon Dr. Lubna's comment about derangement of LFTs that is associated with liver enzyme derangement. Remdesivir itself, it causes ALT-AST derangement. And did you notice that in the patients who develop liver enzyme derangement, did it come down after the dose of remdesivir was completed?
Okay, for that I would like to comment on one thing. Remdesivir started coming in Pakistan at around the month of July. Our study was from the month of April to the end of June to July. So we did not include patients with, we couldn't include patients with remdesivir. However, the patients who were included in our study, they were, at that time, plasma exchange was the new thing. So patients were given plasma exchange, tocilizumab, and other antibiotics who were included and who were given as part of the treatment protocol for COVID-19.
Just a quick thing, timekeeping. I'm sorry.
What about other concomitant bacterial infections in these patients? Those were excluded because these patients have multiple infections as well, apart from COVID.
No, they were all included.
Co-infections are
They were all included because this is a complete scenario of a patient. We can't really exclude someone with superimposed UTI or superimposed HAP because this is meant to happen if somebody who is staying in the hospital for too long.
Okay, I think
housekeeping announcement. Asif, I'm taking over. Can we put a timer on our presentations? I know the presentations are 5 minutes. Hum sare, including myself. I think this is a very interesting study. So hum bolte ja rahe hain, but this session has to finish at 12 because us pe jo ACLF ka, that can't wait. So I think we'll have to make sure everybody gets a chance. I'm sorry for interjecting, but please timer laga dein. Iske upar aata hai timer?
No,
timer site पे डिस्प्ले करते हैं, हमें पता होगा कितना टाइम गुजर गया, हम रोक देंगे वहां पे फिर.
रिकॉर्डेड के बाद जो क्वेश्चन आंसर है उसकी 3 मिनट्स है, तो दैट शुड बी टाइम्ड.
आपके पास कितना टाइम? आपके पास 10 प्रेजेंटेशंस रहती हैं अभी.
We have 8 more
minutes हैं, and then you so 20 minutes ऊपर लगा लें तो 60. तो आपके पास तकरीबन कोई 2 मिनट है उसके लिए. तो आप प्लीज उस पे मुझे या जिसको भी आपने कहें बस काफी हो गया, आगे चलें.
Okay. That's fine. So our next presenter will be Dr. Muhammad Ali Qadeer.
Good morning, everyone. I'm much obliged being one of the speakers here in this annual meeting by PSSLD. My name is Dr. Ali Qadeer, and I'm a fellow resident of gastroenterology and hepatology at Ziauddin Hospital. The title of my research is PNPLA3 gene single nucleotide polymorphism and its effect on liver fibrosis, steatosis, and insulin resistance in patients with non-alcoholic fatty liver disease. We are all familiar with the fact that obesity is on a rise. And with this rising trend of obesity, there is a proportional rise in NAFLD throughout the world. Studies have pointed that NAFLD is a multifactorial disease with genetic polymorphism also being associated with increased steatosis in hepatic parenchyma. Now, NAFLD-related cirrhosis has become a leading cause of liver-related mortality and a principal indicator for liver transplantation. Now, advances in human genetics present new opportunities to address the unmet need for NASH therapeutics. And these new findings have opened up the possibility of precision medicine for patients with NASH based on inherited genetic variants. Talking about PNPLA3, PNPLA3 is a 481 residue protein and is observed in various tissues, but is mostly expressed in liver and retina. The PNPLA3 protein has a lipase activity towards triglycerides in hepatocytes and retinal esters in hepatic stellate cells. And the isoleucine 148 methionine substitution leads to the loss of its function. This is a slide that explains the proposed mechanism of the injury caused by mutation in PNPLA3. On the left-hand side, we can see a normal hepatocyte and a normal stellate cell. The triglycerides are converted into fatty acid and glycerol, and these fatty acids are further converted into VLDL and are excreted out. Whereas retinyl esters in hepatic stellate cells are converted to retinols and they are excreted out as well. Whereas on the right hand side, we can see that the hepatocyte and stellate cell has a mutated version of PNPLA3. Now what it does is that the triglycerides and retinyl esters are not converted into fatty acids and retinols respectively, and their accumulation over a period of time leads to injury to the hepatocytes and leading to fibrosis and cirrhosis. The cytosine to guanine transversion in RS738409 position causes an isoleucine to methionine exchange at amino acid position 148. This mutation has been shown to influence not only intrahepatic remodeling but also reduces VLDL secretion into the bloodstream. This genetic variant, referred to as PNPLA3 I148M, is associated with hepatic steatosis, steatohepatitis, elevated liver enzymes, and hepatic fibrosis and cirrhosis. In our research, the case record of 62 NAFL patients of age more than 18 was evaluated prospectively. PNPLA single nucleotide polymorphism was evaluated by using amplification refractory mutation system polymerase chain reaction. Specific set of primers were used to detect C to G single nucleotide polymorphism on the basis of annealing temperature, prevalence of genotype that are CC, CG, and GG were also assessed. Liver fibrosis, steatosis, and insulin resistance were assessed as covariates. A total of 62 patients were enrolled, 47 of them were male. Out of these 62 patients, 21 had diabetes, 13 were hypertensive, and 38 had dyslipidemia. Now this pie chart depicts the prevalence of different PNPLA genotype in the study population. We can see that the most prevalent of the genotype was CG, which was almost 65%, whereas CC was 19.4% prevalent in our study population, and CG was 16.1%. C allele was found to be present in 51.6% of the study population, whereas G allele was 48.3% prevalent. Patients with positive G allele were found to have elevated BMI and gamma GT with a p-value of 0.039 and 0.027 respectively. Here in this bar chart, we can see that the mean value of BMI in G allele positive patient was 31.4, whereas in patients who were negative for G allele, the mean BMI was 27.31. Now this had a significant p-value. On the right-hand side, we can see that the mean value of gamma GT in patients who were positive for G allele was 102, and the mean value of gamma GT in patients who were negative for G allele was 53. Now, this again had a significant p-value. Out of 43 patients with elevated ALT, 36 were found to be positive for G allele. That accounted for 84%, whereas 19 patients with normal ALT, 14 were positive for G allele. That again accounted for almost 74%. However, p-values between these two groups was calculated to be insignificant. HOMA was also calculated, and it was done in 27 patients. 23 out of these 27 patients had HOMA of 2 or more. And of these 23 patients who had elevated HOMA values, 20 were positive for presence of G allele. Now here in this bar chart, we can see that the mean value of HOMA in patients who were positive for G allele was 4.7, whereas mean value of HOMA in patients negative for G allele it was 3.1. 37 out of 62 patients underwent transient elastography. Controlled attenuation parameter was mild in 10 patients, moderate in 7 patients, and was severe in 20. 17 patients falling into severe category were positive for G allele. 22 patients who underwent transient elastography were found to have liver stiffness of 9.6 kPa and or higher values. 19 out of these 22 patients were positive for presence of G allele. Now in conclusion, PNPLA CG was the most prevalent of the genotype among our patients with NAFLD, and presence of G allele was associated with higher BMI and raised gamma GT. However, no significant difference could be measured in ALT and HOMA between the two groups, that is, patients who were positive for G allele and negative for G allele. Further studies with larger sample size are required for further evaluation of different parameters, including ALT, HOMA, and transient elastography. Thank you.
Yes, please start the timer for 2 minutes. We only have 2 minutes for maybe 1 or 2 quick crisp questions, if anyone has any, or any comments. Yeah, go ahead.
Liver biopsy was done in these patients?
No, sir, it was not done.
Or NAS score was?
Actually, we included patients who already had steatosis and concurrent running some metabolic diseases, and most of them had deranged liver enzymes. So after excluding all the viral causes and drug-related problems to the liver or alcoholic liver disease, they were all excluded out, and only the patients who had fatty liver, they were included. Most of them had steatosis evident by ultrasound.
What's the clinical implication of this in the long run, do you think?
Actually, we all are facing one of the problem in our OPD is that most of the patients who are having abnormal liver enzymes, there comes a time when we don't have any reason to explain what exactly is going wrong. We have excluded all the metabolic reason, including diabetes, hypertriglyceridemia, hypercholesterol, and all the viral causes. Then this is one of the things that recently came into play, that this genetic polymorphism is one of the things that might cause abnormal liver enzymes, and over the period of time it might cause even cirrhosis. So if we found someone to have positive PNPLA, that is by presence of a G allele, we might advise him some different thing as compared to patients who are having hypertriglyceridemia, diabetes, or something else. Because in these patients, the weight reduction have 2 times more effects rather than anything else. Sure.
Thank you.
Thank you. Jadoo.
Okay. So our next presenter is Dr. Raja Taha.
Hello and good afternoon, everyone. I am Dr. Raja Taha Yaseen Khan from the Department of Hepatogastroenterology, SIUT. And the topic of my today's oral paper presentation is low platelet to WBC ratio in predicting mortality among patients with acute on chronic liver failure. So acute on chronic liver failure is a critical clinical syndrome involving acute hepatic insult, which is manifested as jaundice and coagulopathy, complicated within 4 weeks by ascites or encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease. So ACLF occurs in approximately 30% of the patients who have been hospitalized with cirrhosis, and also has a short-term mortality of 50 to 90%. In ACLF, there is increased susceptibility to infection due to impaired inflammatory response and immune dysfunction, which can also be the cause of high mortality in these patients. So these are the scores which have been used in the previous studies to predict the mortality in patients with acute on chronic liver failure. So, but there is this score, like platelet to WBC ratio score, have never been used. This score not only heralds the risk of infectious complications, but also predicts the poor outcome in the patients. And significant amount of research work has been performed to evaluate the platelet to WBC ratio in predicting prognosis in patients suffering from various diseases. But little work has been done in this part of the world to use this relatively simple tool in predicting outcome in ACLF. So the aim of our study is to evaluate the patient's platelet to WBC ratio in predicting mortality with acute or chronic liver failure. All patients fulfilling the criteria for acute or chronic liver failure were included in the study, and the patient's baseline characteristics were recorded. The outcome in terms of mortality was also noted, and these indices were then used to calculate the platelet to WBC ratio. So the total number of patients included in the study were 63. Among them, 41 were males, while 22 were females. The most common cause of chronic liver disease in our patients was viral hepatitis, followed by the autoimmune hepatitis. The most common cause of acute insult was noted to be hepatitis E virus, followed by the drug-induced liver injury. Out of 63 patients, 26 patients expired, while 37 patients were discharged. So this table shows the comparison of continuous variables between the mortality and the non-mortality group. In this chart, it shows that age, increased age, TLC, serum creatinine, total bilirubin, with highest CTB MELD score, along with that high low platelet to WBC ratio. These factors were associated with increased mortality as suggested by the p-value. So this is the comparison of the categorical variables in terms of mortality, and you can see here that age greater than 40 years, with the patients presenting with the renal failure, the patients having CTB score greater than 13, MELD greater than 30, the patient having history of infections and more than 3 organ failure, they had the high rates of mortality as compared to the other patients. This is we have discussed in the chart form. This is written in the table form as well. So an ROC curve was drawn for platelet to WBC ratio, and the P under the curve was 0.71 with the p-value which was significant of 0.01. So this is the box plot which shows that the patients who had mortality had the low platelet to WBC ratio as compared to the patients who had who were discharged from the hospital. It is also signified by this chart which shows that the platelet WBC ratio less than 8 was more mortality group as compared to the non-mortality group. So at a cutoff of less than equal to 8, the sensitivity was 81%, the specificity was 50%, the negative predictive value was approximately 81%, and the positive predictive value was approximately 50% for PWR ratio in predicting increased mortality in patients with ACLF with a diagnostic accuracy of 70% respectively. To conclude, low platelet to WBC ratio was associated with an increased risk of mortality in patients with acute or chronic liver failure and was found to be an independent predictor of mortality. Thank you.
I could see his face because वो कह रहा था यार मैं इधर बैठा हूँ और आवाज सही नहीं आ रही तो तुम ये जरा गड़बड़ हो गई थोड़ी सी, but I think everybody heard you well. It's not a problem. ये जो platelet count है, do you think this is a surrogate marker of underlying chronic liver disease कि ये it's something to do with the acute liver failure?
I think in chronic liver disease we see decreased platelet count likely secondary to hypersplenism, and along with that, if the patient is having some underlying sort of sepsis, so we can also have low platelet count in that case. So basically this whole marker has been used previously in to predict in certain studies to predict inflammation and associated mortality. So we tried to use this in predicting the mortality in acute on chronic liver failure.
Taha, basically in your study, the sensitivity was good, but the specificity was 50%. Usually any test or anything to be have an impact, it should have at least 70-75% sensitivity and specificity.
Yeah.
So what do you think? What are your comments regarding that? Regarding the low specificity?
I think because of the limited sample size I had, so we had to increase the sample size, for the future studies in order to have the high specificity and look for high specificity of the test.
So did you calculate the sample size before you started this study?
Yeah.
How much was the sample size, or so that in that case, if the sample size was less or something, or it's an ongoing study or what?
So
you must have calculated the study before you started the study.
So basically, the statistician was also involved, and then we calculated the sample size, and then the whole thing was done.
I think the question is, this is a very important
question. So what was the sample size?
Basically, the sample size was 63.
Calculated. What did you think you will need?
Calculated sample size. You said that the sample size was small. That's why the specificity was not that high. So what was the actual sample size? Otherwise, 50% is very low. It's not acceptable as a standard.
That's okay. I think the point we are making is that before you start a study and you want to study significance, you determine what is the sample size you would need.
Yeah.
Now, it's okay to present your data like this, but say that you did not calculate the sample size beforehand, because abhi aap isse kuch conclude kar nahi pa rahe aap isse. But it's a good, I think overall it's a good effort, but this is a very valid comment Dr. Lubna just made.
Yeah. Okay. Thank you. So next presenter will be Dr. Asha Devi.
आपका टाइमर नहीं आ रहा स्क्रीन पे, प्लीज उसको देखें. IT team, please, timer was not there on the screen this time also.
Good evening, everyone. I am Dr. Raja Devi. I am resident gastroenterology and the department of SIUP, Karachi. And my topic of presentation is Hepatoma Arterial Embolization Prognostic Score as a predictor of hepatic decompensation in patient with hepatocellular carcinoma treated with Transarterial Embolization. So, introduction, as we all know that liver cancer is the most common cancer, and it is the most common cause of morbidity and mortality among patients with cirrhosis. And 50% of these patients become the candidate for local regional therapy, with an increased survival of 11 to 20 months. Moreover, especially in BCLC B class, therapeutic response is highly variable. Therefore, these patients need to be evaluated beforehand to avoid morbidity and mortality. So, response. As per AASLD guideline 2018, response to HCC depends upon the hepatic reserve and tumor characteristic. So combining these variables, and Al-Qadali et al. Demonstrated a score which is known as Hepatoma Arterial Embolization Score, which predicted overall survival in patients with hepatocellular carcinoma undergoing transarterial chemoembolization. So these are the factors, prognostic factor, which are compromising HEP score. So these factors include albumin, alpha fetoprotein, bilirubin, and maximum tumor size. Individual variable has been given 1 point and total score is of 4, and any score more than 2 was considered to have high mortality. Muhammad Ali Qadeer et al. And Tasneem et al. Both have demonstrated, as well as there are multiple studies that have demonstrated that larger tumor size, high serum alpha-fetoprotein and lower serum albumin, they have predicted decompensation following TACE. So as you have seen that variables of Hep score are similar to those factors that predict decompensation. So our aim is to evaluate Hep score as a predictor of hepatic decompensation in hepatocellular carcinoma patient undergoing TACE. So patients who are diagnosed with hepatocellular carcinoma falling into BCLC-D criteria are included in our study, and patients who are awaiting for liver transplantation. We have excluded patients with decompensated cirrhosis and who have poor functional status. So after meeting inclusion criteria, patient Hep score was calculated, and we have divided patient into 2 risk groups based on the Hep score. Those who have Hep score less than 2 were classified into group A, and those who have Hep score more than or equal to 2 were classified into group B. So these are the baseline characteristics of the participant. Among 64 patients, and the mean age of the patient was 53 years, while mean CTP and MEL score was 5 and 9. And mean alpha-fetoprotein was 4,581, and albumin was 3.2, and tumor size was 4.8. Majority of the study population were male, which includes 73.4%, and we have further stratified the patient based on the tumor size as an alpha-fetoprotein. Majority of the patient has tumor size less than 7 centimeter and alpha-fetoprotein less than 400. The most common etiology of hepatocellular carcinoma is hepatitis C, followed by B, NASH, and both B and C. Patients were among study population, 30 patients were found in group A. They have Hep score less than 2, and 34% were found in group B. They have Hep score more than 2. In our study, 36% of the population has been decompensated after TACE. And as you can see in this box plot chart, and those patients who decompensated have a Hep score higher than 2 or higher Hep score. So in conclusion, Hep score is a simple and easily calculated scoring system that can be utilized to save the patient from deleterious complications after TACE. However, further studies are needed to validate this score in our population. Thank you.
Any question or comments?
पहले पर मैं पूछ लूँ क्योंकि बड़ा मुश्किल सवाल पूछती हैं आमतौर पे. Quickly, so I didn't quite get towards the end. थोड़ा सा abrupt end था because I couldn't get कि क्या difference था दोनों groups में. पहले have जो less than 2 or greater than 2.
Sir, we have classified the patient based on these 4 factors, which include albumin, bilirubin, tumor size, and alpha-fetoprotein. So if a patient have any of the 2 or more than 2, though we have classified the patient based on, we have taken the cutoff point of 2.
So groups A और B में क्या difference था?
Group A में those who have a low Hep score.
No, I understand. But उन दोनों में क्या difference था? उसमें से कितने decompensate किए A में से और B में से कितने decompensate किए?
So total 36% has been decompensated. Among them, जो है more of the patient were found in group B. Those
more तो नहीं answer ना, इसका number क्या है उसका?
Number, so total 23 were decompensated. Among them, 18 were in group A, and 18 were patient found in group B, while 6 were in group A.
So you have mentioned it in slides में. I think this is the important. Ji, go ahead. Right? That's okay. I mean, I'm just pointing it out. कि आपने more is not a statistical number.
18 and 6.
Oh, that's a big difference. So it's or statistically significant.
Yes, sir. It was statistically significant.
Good. That is nice. Very nice study.
So our next presenter will be Dr. Arth Muhammad.
टाइमर ना है आपको नाराजगी आपकी यार.
Assalamu alaikum. I am Dr. Arth Muhammad. GI resident from Sindh Institute of Urology and Transplantation. Today my presentation is about virological response of Sofosbuvir and Declartosavir based direct antiviral regimes in children with hepatitis C infection. Hepatitis C infection is the remains an important global health problem, the chronic infection affecting approximately 11 million children worldwide. Currently, most new hepatitis C infected cases are thought to occur through the vertical transmission, and the treatment options for the children are currently limited according to the recent guidelines. For patients, pediatric patients, a new era of highly effective direct antiviral agents is beginning, and the first results of available clinical data are very promising. So the aim of our study was to determine the efficacy of direct antiviral agents in children with the chronic hepatitis C infection. The children with less than 15 and hepatitis C infection were included in this study, and the patient's baseline characteristics were recorded. The treatment regimes and the duration of treatment were also recorded as rapid viral response, early viral response, end of the treatment response, and sustained viral response in 12 weeks as well as also 24 weeks. The results were presented as mean standard deviation for quantitative data or as a number with the percentages for qualitative data. The continuous variables were analyzed using the student t-test, while the categorical variables were analyzed using the chi-square test. A p-value of less than 0.05 was considered as statistically significant. Among the research population, the total number of the population were 26. Out of them, 6 were the females, while 20 were the females. These are the baseline characteristics: age, weight, hemoglobin, total leukocyte count, platelets, INR, serum creatinine, total bilirubin, SGBT, SGOT, alkaline phosphatase, gamma GT, sodium, and albumin. The mean age was 11.2, whereas the weight of 28.1, and hemoglobin of 10.5, total leukocyte count of 11.8, INR 0.9, serum creatinine 3.08, total bili 0.5, SGPT 31.03, SGOT 34.1, alkaline phosphatase 285, whereas the gamma GT 26.5, sodium 137.3, and albumin 3.7. Most of the pediatric population present in our setup have the genotype 1 followed by the genotype 3. 12 out of 26 patients have the genotype 1. The patients were divided in two groups, those patients who received the SOF and DECLA. 14 patients out of 26 received Sofosbuvir and ribavirin, while 12 patients received the triple regime therapy, including Sofosbuvir, Declartosavir, and ribavirin. Here is the bar chart that shows the patients who received Sofosbuvir and ribavirin. 9 of 14 patients received the treatment for 6 months, while those patients who received the triple regimes of Sofosbuvir, Declartosavir, Decla, and ribavirin, only one patient required the 6-month treatment. And the rapid viral response was achieved in 35.7% in the SOF and RIBA group, while those patients who received the triple regime therapy, SOF, DECLA, and RIBA, 91.6% achieved the rapid viral response with a significant p-value of 0.003. Similarly, in the end of the treatment response was achieved in 64.2% in group of patients who received the Sofosbuvir and ribavirin, while 100% in the patients who received SOF, DECLA, and RIBA triple therapy with a significant p-value of 0.021. And those patients, the sustained virological response 12-week and 24-week was achieved in the 100% of the patients who received the triple regime therapy with a significant p-value of 0.003, and only 71.4% who received Sofosbuvir and ribavirin. It's concluded that the triple therapy with Sofosbuvir, Declartosavir, and ribavirin was associated with a better outcome and prolonged sustained virological response in children with a hepatitis C infection. Thank you.
Thank you. I will ask Dr. Lubna for any comments or question.
Dr. Als, did you, by looking at the baseline characteristics of this patient, of these patients, looks like these patients were not cirrhotic and children are rarely cirrhotic. Did you do a fibroscan in these patients?
No,
basically to find out the fibrosis score, because you've added ribavirin in all the patients, and according to guidelines, if the patient is not cirrhotic, does not have fibrosis, then ribavirin is not indicated. The SOF and DECLA is fine, and you've given it for 6 months. So in few of the patients in both the groups. So why?
Ma'am, actually,
because 6 months are generally given for the advanced cirrhosis or those who did not respond early.
Ma'am, 6 month regime was given in those patients. Although we did not go for the elastography and we included those patients who were not cirrhotic patients or not cirrhotic patients, and we increased the duration of treatment in those patients who did not achieve the RVR in early phase, RVR or EVR. So we increased.
So you have to tell us that how many patients did not receive achieve the RVR. So that's why the treatment was prolonged. You said that we did not included the cirrhosis, but you never did fibroscan. So if fibroscan was not done, how can you find out that these patients were not cirrhotic? And why ribavirin was added in all patients?
Ma'am, based on the clinical parameters, as we have seen the platelets and ultrasound basis and the platelets in the CBC.
But fibrosis will not tell you. Fibrosis is different, exactly. CLD is different, and decompensation is different. So if patient has F3, F4 fibrosis, the platelets can still be normal. The albumin can still be normal.
Ma'am, as this is also the previous data before 2017, and this study is ongoing. At that time, there was no availability of fibroscan, so we included, and currently it is ongoing study. We will include also fibroscan in these patients.
And why on the first thing that you added ribavirin in all these patients? Because ribavirin is usually added in CLD patients or treatment failure patients. So in treatment naive, non-cirrhotic, no fibrosis, ribavirin is usually not added according to guidelines. So any specific reason? I know with ribavirin the response rate is much better. I add ribavirin on day-to-day basis. I'm not saying that it's a very good, it's a magical drug and it gets for free also. But why?
Ma'am, as per institutional protocol, we have SOF and RIBA.
Thank you. I will ask Shahid Rasool if he has any comments. I think he has some connectivity problem at the moment. So we'll proceed with next presentation, and we'll take Shahid Rasool. After that, connectivity problem resolved. So our next presenter is Ghosh Bakhsh Sumro.
Bismillah ar-Rahman ar-Rahim. I am Dr. Ghosh Sumro. So, I am presenting pediatric liver cirrhosis in patients, etiology, clinical presentations, and outcome. Liver cirrhosis is an important cause of morbidity and mortality among the pediatric patient. In the pediatric population, it encompasses a wide spectrum of disorders, including chronic metabolic like Wilson disease, alpha-antitrypsin, vascular disease like Budd-Chiari syndrome, genetic disease, cystic fibrosis, alpha-antitrypsin, viral infection like Hepatitis B virus, autoimmune hepatitis, and structural disease like polydocal cyst, Carolese disease, etc. Besides, the causes of liver cirrhosis in pediatric patients may vary depending on the age and the geographic region. Aim of the study to identify the etiology, clinical presentation, outcome of pediatric in patient with liver cirrhosis. Methods. In the retrospective study, all pediatric age less than 16 years cirrhotic patients requiring hospital admission over last 10 years were included. Patients with other organ failure like end-stage liver renal disease. Cirrhosis was diagnosed on the basis of clinical features like history of ascites, GI bleeding, hepatoencephalopathy, imaging findings like ultrasound abdomen to see the splenomegaly, ascites, shear wave elastography shows the advanced fibrosis like fibrosis F4. Upper GI endoscopy to rule out the esophageal varices, histology, then the liver biopsy. Etiologies of cirrhosis is according to age groups, clinical presentation and outcome of these patients were recorded. Results. Total number of patients 181, male patients were 115, mean age was 8.6, the range 2 months to 16 years. Commonest etiologies of cirrhosis were classified according to age group of pediatric patients less than 1 year, 1 to 5 years, more than 5 years, less than 10 years, and more than 10 years. The etiology of the cirrhosis remained unclear despite extensive investigations among 22 cases. These etiologies of cirrhosis in pediatric patients according to age groups, the age is less than 5 years, the number of patients 10, etiology of cirrhosis is biliary atresia, more than 1 year and less than 5 years, the 41 patients, etiology of cirrhosis is hepatic storage disease, cryptogenic cirrhosis 8 patients, Budd-Chiari syndrome 6 patients, PFIC 5 patients, autoimmune hepatitis 4 patients, biliary atresia 3 patients. Hepatitis B virus 1 patient, Wilson disease 1, primary sclerosing cholangitis, tyrosinemia, alpha-1 antitrypsin, cystic fibrosis 1 patient. More than 5 years and less than 10 years 61 patients. Etiology of hepatitis B virus 17 patients, autoimmune hepatitis 11 patients, cryptogenic cirrhosis 10, Budd-Chiari syndrome 6 patients, Wilson disease 6 patients, hepatic storage disease 3 patients, PFIC 2 patients, hepatoblastoma 2 patients, Carolese Alagille syndrome 1 patient. More than 10 years 61 patients, etiology of cirrhosis hepatitis B virus is 24 patients, autoimmune hepatitis 17 patients, Wilson disease 10 patients, cryptogenic cirrhosis 6 patients, PFIC and hepatic storage 2 patients. Endemic childhood cirrhosis and hepatitis C virus 2 patients, Budd-Chiari syndrome, secondary biliary cirrhosis, biliary atresia, Crigler-Najjar syndrome type 1 patients. Clinical presentations, commonest clinical presentation include the upper GI bleeding in hepatitis B virus, failure to thrive, biliary atresia and hepatic storage disease, progressive severe itching in patients biliary atresia and PFIC, progressive ascites, Budd-Chiari syndrome, respiratory urinary tract infection in autoimmune disease, acute and chronic liver failure, hepatitis B, autoimmune Wilson disease, and Indian childhood cirrhosis. Portosystemic encephalopathy present with Wilson disease. This is the etiology of cirrhosis. Hepatitis B most common in children. The number of patients 42. Most commonest reason for the hospital admission, acute and chronic liver failure 42.8%, upper GI 23.8%, pre-liver transplant workup 16.7%. Autoimmune hepatitis 32 patients, febrile illness 59.4%, acute and chronic liver disease 21.8%, portosystemic encephalopathy 18.7%. Cryptogenic cirrhosis 24 patients, they are present with ascitic fluid infection 45.8%, portosystemic encephalopathy 33.3%, for liver biopsy under GA 16.7%. Wilson disease 17 patients, they are present with the portosystemic encephalopathy 47.1%, acute and chronic liver disease 35.3%, Wilson in crisis 11.8%. Biliary atresia 14 patients, they are mostly present with worsening jaundice and itching and failure to thrive. 71.4% is worsening of itching and jaundice, and 28.6% is failure to thrive. Hepatic storage disease, 14 patients, they are present with the failure to thrive in admission, 64.3%, recurrent hypoglycemia, 21.4%. Budd-Chiari syndrome, 13 patients in hospital admission, reason for progressive ascites, 53.8%, for CT scan under GA, 38.4%, progressive familial intrahepatic cholestasis disease, 9 patients, and their reason for admission, worsening of jaundice and itching.
Right. I think in the interest of time, we had to stop it. Dr. Sumro, can you please just quickly give us the conclusion and the results of your study? Can you please put the mic on? Yeah, it's on.
So, in my conclusion is our pediatric cirrhosis patients, 181 patients with their follow-up in 116, they are died into 37 patients, and the 29 is the last to follow-up. So the clinical presentations and etiology and outcomes, see the outcomes of the patients, they are, because the patient all are the cirrhosis, not chronic liver disease. So we are see the patients to etiology and the liver biopsy and some imaging and the clinical presentations, upper endoscopy. They are number of the children were follow-up 116. Thank you.
Thank you, Dr. Sumro. So we will going to next presentation due to short up time. Next presenter will be Dr. Masood Karim.
Assalamu alaikum and good morning everyone. First of all, I'd like to thank PSSLD committee for providing me the opportunity to present my oral abstract. Without further delay, I'll talk about my presentation. The title of my abstract is Recurrence of PSC in Cirrhotic Patient and its Risk Factor. I have nothing to disclose. My presentation outline would be introduction, rationale and objective of study, material and methods, result, conclusion, and the limitation of the study. Portal systemic encephalopathy is a common complication of cirrhosis that places high societal burden of illness and hospitalization. The recurrence of PSC in cirrhotic patient is associated with worse outcome in terms of disease progression and with deterioration of quality of life. Our rationale of our study is to assess the risk factor for recurrent PSC so that appropriate prevention and prognostication can be done. Identifying the risk factor for the PSC may allow for closer monitoring to preserve quality of life, reduce and manage the risk factor accordingly. The objective of the study is to assess the recurrence of PSC in cirrhotic patient after first episode of PSC and its risk factor. This study was retrospective, single center, conducted at Khan University Hospital. The duration of the study was 1 year, from 1st January 2019 to 31st December 2019. All cirrhotic patients were included in this study with a diagnosis of PSC, index PSC, first time presenting with PSC. Those all were adult population. Non-cirrhotic patients, cirrhotic patient with prior history of PSC, patient with HCC and metastatic diseases, CVA and other CNS pathology, and documented psychiatric illness were excluded. Chart review of recruited patient were done and their variable were recorded. Records of recruited patient were reviewed for 3 months after index PSC whether they needed admission for recurrence of PSC. The variables of patient who developed recurrence of PSC and those who did not develop the PSC were compared and statistical analysis were done. A statistical analysis performed using SPSS version 20. The variables which were analyzed were age, gender, comorbids, etiology of cirrhosis, MELD score, Child-Pugh score, PSC grades, serum sodium, potassium, INR, creatinine, albumin at the time of index PSC admission. Unpaired t-test was used for continuous variable and chi-square test were used for categorical variables. We had total 61 patients in the study, 10 lost to follow-up, 15 remained in the study. Total 50 patients after 10 patients who lost to follow-up. Those patients developed recurrence of PSC were 33 and those who didn't were 18. In the result, we can see the baseline characteristic of all patients of 51 patients. Age is 59 plus minus 10. In the gender, we can see the male predominance 57%. And in comorbids, hypertension is 64 and followed by diabetes 54%. As per the etiology of cirrhosis, as majority of patients are seen HCV 59%, followed by B, alcoholic, others. And if we talk about PSC grading, the most of patients were 59% were PSC grade 4, 3 and 2, and none of them were in PSC grade 1. Same as for the Child-Pugh, we can see in C, there is a majority of patients here, 76, followed by B, and none of patients were in Child-Class A. We talk about now precipitating factor. We can see here in urinary tract infection seen in 10 patients, AKI in constipation 8, hyponatremia 9, hypokalemia 7, and SBP in 6, and GI bleeding 9. If we closely look into this infection, UTI and SBP, if we add them, they become 30%. So by combining them, we can say the infection was predominantly seen precipitating factor in this group of patients. And MELD score greater than 18 seen in 65% of patients, while the bilirubin less than 3 is seen in majority of patients 49, 3 to 6 seen in 41%, and greater than 6 seen only in 5 patients. No. And if we talk about albumin, so albumin seen 3.5 greater than 3.5 in 41, 2.8 to 3.5 in 20, and less than 2.8 seen in 19% of 10 patients. So after seeing all the baseline characteristic and the precipitating factor of the group, the total patients, now we combine, we just compared the both groups, those patients who develop recurrent and non-recurrent group. So multiple variable like age, infection, MELD, INR, albumin, creatinine, sodium, potassium, CTP score, and total bilirubin were compared in both groups. As we can see, age at 57 and 55 plus minus 6 is not that much significant, but we can see here infection, it's seen 60% of patients with recurrent PSC, while in 22 in non-recurrent. That is significant P value is noted here. And as well as for the MELD score, 19 plus minus 2, while in the non-recurrent it's a 14. So that's also significant. Same is for the albumin and total bilirubin. So 4 variables are significant, while the rest of the variable, creatinine, sodium, potassium, Child-Pugh score, age, were not that much significant. So in conclusion of our study, we found higher MELD, raised total bilirubin, low albumin, and infection were the risk factor for the recurrence of PSC. Identifying the risk factor during assessment can reduce the recurrence of PSC. We also would recommend to validate our study on larger scale prospectively. Our study is also some limitation. It was single center retrospective with a small sample size. Socioeconomic and nutritional assessment were not done. Patients were followed on shorter period of 3 months only. Thank you.
Thank you, Dr. Masood. Due to time limitation, I will take.
Hello.
Ji, Dr. Lubna.
Yeah, I have couple of questions from Masood.
Okay.
Masood, you said that first of all, the infection is like in UTI you had 19% and in the SBP you have 11%. If you combine it will be 30%. No, it's not like that in statistics, because there will be multiple patients who have both the UTI as well as SBP. So there will be lot of overlap in your patients, in the cohort of patients. So first of all, how many of the patients had both UTI and SBP, and what about sepsis? What about the blood culture? Second question is, what was the most common organism? Was it fungal UTI? Was it bacterial UTI? My third question is that in SBP, if it was culture negative SBP or culture positive SBP? So these will all highlight the importance of infection basically.
Thank you, Dr. Lubna, for these questions. So as our study was retrospective, we just did a chart review of those patients, and these all diagnoses were the clinical and supported by some evidence, like even some patient there were culture positivity was there, but and the clinical diagnosis we also preferred in the chart review, whatever the which was written in patient's file. Second, the infection of the patient coming with UTI and SBP, both were, we just mentioned them, they were different. Those were UTI were 19% and those with SBP was 11. So we didn't see a combine both of them.
None of the patient had combined no UTI and SBP together in one patient. You have to look it carefully.
So whatever the chart review we have seen, this was the limitation for our study. So whatever chart review we have seen, we found these patients.
And what about how many were culture positive SBP and culture negative SBP? Because many years ago I did a research on this topic at Aga Khan, and the culture positive SBP had high mortality and high risk of PSC as compared to culture negative. So this point is important if you're talking about recurrence of PSC. Was culture negative or culture positive SBP is related to more recurrence of PSC? So that would be an important point. Plus, what type of UTI was more indicative of recurrent PCI? Was fungal infections were more deadly? So this was again this important point. Plus, you said that infection had a high rate of recurrent PSC. So the question arises, was the infection was not treated adequately at the first place, or it was partially treated? That's why these patients are again admitting with the infection and again coming with PSC? Or what was the risk factor which was not taken care of? So these are important. I know that retrospective study has its own limitation, but you need to incorporate, because this will be there in the file, that how many days or weeks they received antibiotics on discharge and what was the culture result. So you can get it from the the charts and the record system of ATU from the computer.
Thank you, Dr. Lubna, for highlighting this. We also planning, as it's a preliminary data of our study, we are also planning the analysis of the this infection and the pathogen which we can see in these patients.
Thank you, Masood. Sorry to interrupt, Dr. Lubna. This is a very interesting topic, but unfortunately we barely have time for only one presentation, and that is the last one.
So I will like Dr. Jalpa to present her presentation. Dr. Jalpa Devi.
Hello.
Yes, Jalpa, we can hear you. You can start.
Thank you so much for giving me this wonderful opportunity. And my topic is targeted read.
Right. So.
Hello. I'm sorry. I'm back.
I don't know why they keep on switching off my mic. This should be need to look at.
Hello. Can I present my presentation? I'm sorry for the internet connection.
Jalpa, I guess, Jalpa, we can give you 3 minutes if you can summarize.
Yes, okay. I will definitely.
Dr. Anna, is that okay? Because she has already prepared and we have 4 minutes, so we can give her 3 minutes.
Okay. Just
go on.
Just can you share my slides or should I just go on? Can you share my slides?
Summarize verbally, quickly.
Okay. So, actually, it was 30-day readmission. What I did that, as you know, that esophageal hepatitis is a fatal GI emergency. We know in hospital mortality in US is 30%, in UK is 23%, and Pakistan it's 20%. And 30-day readmission after index admission in USA is 16.6% and in UK is 15%. But in Pakistan, we don't have that such data because the 30-day readmission is actually a quality metric for several diseases, including like congestive heart failure, MI, pneumonia. And in our healthcare delivery system, we should be not looking for services that we provide, but we must look for healthcare quality and cost effectiveness. So, because if patient readmission is again and again, then it will be a harmful and to the patients and burden to caregiver and as well as healthcare system. So we should understand that why, what is the trends of the readmission and what are the factors that we can prevent it. So I look for my primary outcome was 30-day readmission rate, and secondary outcome was in hospital and 30-day mortality rate among index admission and causes of readmission, and then index in hospital mortality rate among readmitted patients and independent risk factors for readmission. So it was a prospective study at AIMS and I look for I followed patients for 30 days from index admission and I called them that whether they got readmitted or not and whether they are okay. So my results were that I had 160 patients with a mean age of 50 and there were 75% were males, and most common etiology was hepatitis C followed by the non-B, non-C. And there was in-hospital mortality that is 9%, and that is index in hospital mortality. 15 patients died during first hospital admission, and there was a readmission. Patients were readmission rate was 15%, which is similar to the almost similar to the UK and USA. And the cause of readmission was rebleeding in 1/3 of my patients, and the rest were with different causes they admitted. And in hospital, in hospital readmission. In-hospital mortality rate is 9.3, 30-day mortality rate is 12%, and in-hospital mortality rate among readmitted patients was 18%. So, the all-cause 30-day readmission rate after esophageal varicose hemorrhage was 15%, with more than 1/3 of cases due to rebleeding. And the readmission is associated with high rates of mortality because my in-hospital mortality among readmission patients was higher. So we should be looking for the factors. I actually did the look for the independent risk factors for readmission like age, gender, Charlson comorbidity index, CTP, MELD, length of stay. But due to the less number of sample size, like my outcome was because I had only 22 patients readmitted, so it didn't come out significant. And between readmission and not readmission. So limitations of my study is that it should be like multi-center and it like national level, and it should be with a large sample size, and we should be working on to see the risk factors for readmission so that we can further prevent the multiple readmissions of the patients. And thank you.
Thank you, Jalpa. I will like Dr. Lubna Kamani to conclude the session.
Okay, thank you very much. I'm sure I was the villain of this session because I asked very difficult questions from the young researcher. But it's good to see that the younger generation is involved, is enthusiastic about the research. So my message is just keep going, because once you are into the research thing, it will get improved over the period of time, and you will get more and more ideas as you move forward in your life. So all the best for your future, this younger generation, and the results will be announced later by Dr. Amna Sophan during the conference. Thank you all.
Thank you very much, and we must appreciate all the chairs of this session. 2 hours non-stop listening speakers and then giving their comments, asking questions, and again the moderators, Dr. Mia Yusuf and Dr. Kamran, who is sitting over here. So 3 hours activity, and they stayed with us. Thank you very much. Much appreciated. And the result will be announced in the closing ceremony, which will be tomorrow in the evening.